Welcome to Ideas of India, a podcast where we examine academic ideas that can propel India forward. My name is Shruti Rajagopalan, and this is the 2025 Job Market series where I speak with young scholars entering the academic job market about their latest research on India. Our sixth scholar in the series is Nayantara Biswas, who is a postdoctoral research fellow at the Beth Israel Deaconess Medical Center. She received her PhD in economics from Clark University. Her research focuses on health equity impact evaluations of small-scale interventions and large-scale public policies. We spoke about her dissertation titled The Impact of Social Policies on Reproductive Health, Maternal Employment and Child Health. Evidence from India. We talked about both demand-side and supply-side policy interventions in public health. India's maternal health policy landscape. The ASHA Workers program and its impact, the variation across states in policy impact, and much more. For a full transcript of this conversation, including helpful links of all the references mentioned, click the link in the show notes or visit mercatus.org/podcasts. Hi Nayantara, welcome to the show. It's such a pleasure to have you here.
Hi Shruti, I'm so excited to be here. As you know, I'm a big fan of this podcast and I'm very, very happy to be on as one of the speakers.
Yeah, I was telling you just before we started recording how much I love talking to people on the job market. Your paper in particular looks at women's reproductive health, child, infant health, and sort of all related outcomes through policy interventions. But specifically, you look at supply side interventions, right? So you look at whether an increase in supply through a particular policy that the government has announced or implemented will actually impact the behavior of those who are on the receiving end or on the people who use that particular policy, and therefore, how it impacts their health outcomes. And in particular, maternal health is obviously a difficult thing to look at because we have very few numbers. Most women are pregnant in India apparently at 2.2 times in their life, which is a strange way to phrase it, but you don't have this large sample size of, number of times a woman gets pregnant in her life. But there is a lot of other things associated with it, such as reproductive healthcare services, antenatal, postnatal care, contraception use, and so on. So there's actually a lot to study when it comes to maternal health. And India performs very poorly when it comes to maternal mortality and things like that. And you look at a very nice policy intervention, which was the ASHA Workers that were launched in India. And you look at how much an additional ASHA worker is sort of associated with utilization of reproductive health services by women in India. And you look at this in an extraordinary way at the district level, which is complicated for various reasons that we can get into. And you actually find that an additional ASHA worker per 1,000 population is associated with 2.04 to 4.1% increase in the utilization of reproductive health services. Is this a good way to think about your paper? And then maybe you can tell us, how you did all of this.
That was an excellent summary, Shruti. I thank you for that. And I also wanted to mention that, it is right now, as it stands, I was looking at the long-term effect of this healthcare policy intervention, which is why I do find such significant impacts. I will say that a lot of work has already been done by public health researchers, and they don't sometimes find these impacts. And that could be because they're looking at immediate outcomes. And especially when you're thinking about changing household behaviors, you do need to give a longer period of time, which is what I've been fortunate enough to exploit that in my dissertation, in my job market paper.
Can you walk us through what is the landscape of women's health, maternal health and mortality, infant and child health policies in India, especially because a lot of these are state subjects. A lot of them are implemented at the district or the panchayat level, but they're announced in terms of outlays by union government schemes. So it's like a very complicated thing. So can you just walk us through what that landscape looks like? And then we can talk about the intervention and the outcomes and what you measure and so on.
Very broadly, my motivation is coming from the fact that India in general has invested in a lot of maternal and child health policies. So Karthik Muralidharan and others, they've recently released a working paper where they shared that cash transfers alone cost 2 trillion rupees per annum. And that's 0.6% of the GDP.
Yeah.
And this is serving over 130 million women beneficiaries who are in the reproductive age. So if you're looking at this as being a demand side investment of just cash transfers being 0.6%, and you're comparing this to India spending 3 to 4% of their GDP on healthcare, that's a really huge investment on just demand side interventions. But however, in this context, we're not fully understanding how do the supply side interventions matter and how do they intersect with these demand side policies. So that is where I come in thinking about this, is that I'm thinking, do more workers actually shift behavior, or is it that culture and social norms, are they more restrictive and are they binding and they impede the utilization of these reproductive health services?
So there are two ways to think about it, right? So someone may be more likely to go to a clinic because they received a health voucher, or they received health insurance, or they received a direct cash transfer. And that changes how they demand a particular health or service which is in their village or their district and so on. On the other hand, people may also be more likely to use a particular service if it is easier to use because of the supply. That is, there's actually a clinic within walking distance, right? The clinic is actually staffed. It has a midwife. It has an ASHA worker. It has enough people within my neighborhood going there that I feel comfortable going there. So that might change my behavior. And as you rightly point out, demand side and supply side interventions can typically be extremely expensive. So as policymakers, when we think about something, we need to look at both the costs and the benefits, right? So there's this excellent paper by Karthik Muralidharan and his co-authors on the demand side, and now you're really looking at the supply side and how that changes women's behavior.
Exactly. That is precisely what I'm trying to do. And I think that exactly how you said it is that unless you have the access to a certain facility or a clinic, then it's really hard. Like, even if I want, say, reproductive healthcare services, I want to give birth in an institution, but if I don't have the access, like you said, or if I even don't have the information access, that is also a form of access, then I will not be able to take up that service. India has made remarkable progress in maternal health as well as child health. And maternal mortality has actually fallen by more than 80% since the 1990s to currently, which is a huge progress. So it's from 560 deaths, which was quoted in NFHS 2 1998-99.
Per 100,000.
Per 100,000, of course, to less than 100 in per 100,000 births. Now, infant mortality has also dropped pretty significantly. But the progress, like you mentioned, is very uneven. Right? The district level variation really exists, and that is kind of the basis of using this district level policy measure for my paper. So, for instance, states like Kerala and Tamil Nadu, they have outcomes which is comparable to middle to high income countries. Right?
Yeah.
Whereas you have other states like Bihar and Uttar Pradesh who are lagging behind by a huge margin sometimes, right? So even within the states, there is district level variation. And the variation is part of the reason of why studying in India is so interesting and so important, because it shows what is possible, but it also shows where the gaps remain.
Now that we've talked about the variation, I guess a good question here is, I mean, Indian states are very different, right? I mean, there's a linguistic factor. There's also the GDP per capita, like Kerala and Tamil Nadu are very rich states. Bihar and UP are technically at sub-Saharan levels of GDP per capita. So there's an income issue. There's also like culture issues, cultural practices. Kerala is very famously a matriarchal society, which is about as far removed as you get from Bihar and Uttar Pradesh and so on. So when you look at behavior of women when it comes to taking up or using more reproductive services or healthcare services, how do you manage to separate the existence or the supply of a particular service from the cultural practices or the norms or whatever exists in that society? I guess that's a good place where you can start us off and it'll set us up well for the rest of your paper.
First of all, let's start with what the ASHAs are. So the ASHA worker stands for Accredited Social Health Activist. And these are community health workers and they are designed in such a way that these are local women and they are chosen from their villages or their towns, and they're trained to link households to the healthcare system. So many researchers, they actually refer to ASHAs as link workers for this very reason. So now they're tasked with a variety of things. So it's not, they initially entered the landscape as maternal and child health care workers, but now they are essentially population health workers. And we saw that particularly during COVID. They were pivotal. ASHAs were particularly pivotal in kind of disseminating vaccine, so, as well as the importance of vaccination, right? Because again, if you don't have education around vaccines, would you really be taking up that vaccination, right? And ASHAs were pivotal because they provide both the information and the access. And that is so unique about them. So a little bit more about this particular policy is that they were paid on a piece rate basis, right? And this is a very unique part of the community health worker system in this particular context, because before ASHAs existed in 1975, the Anganwadi workers were also introduced, right? But they were a little bit different from ASHAs because they were in charge of these Anganwadi centers and they were kind of giving out a lot of different kinds of like benefits, even though it was more to do with maternal and child health. And similarly, in 1956, you had the auxiliary nurses and midwives. But these are very trained healthcare workers. So now when you're thinking about ASHAs, they are not as trained. These are middle school graduates. They are 25 to 40 years old. So they were very mobile workers. And one of the very interesting requirements was that they had to be a married resident of the village. And a lot of people ask me, why is that? Well, that's because India follows a patrilocal system. Right? So you want somebody in the village who you can refer to even like during like later years of your reproductive health. And this is a very known person in the village who understands the culture, who understands all of these like shared practices. And particularly here, I would want to refer to S. Anukriti's and others' paper called The Curse of the Mummiji, where they very clearly showed that reproductive health decisions is not borne by women alone.
It's a family decision.
It's a family decision. And it's usually in-laws and such who will come in and will say that, okay, you get to seek this healthcare services versus you don't. So it's not just about educating the mother, it's also about educating the entire household. And that is why ASHAs, they serve as this liaison between the community or the household as well as the healthcare system. This is particularly important, I want to highlight in the Indian context, because, and this is from a Times of India article where they surveyed Indians, and they showed that Indians have over a 90% institutional distrust. So meaning that Indians just do not trust public or private healthcare systems. And we can think about this from many different angles, but if you do not have trust in a particular service, you are not going to be seeking help in that formal institution. And again, that is where ASHAs are coming in as this informal kind of a gap that they are bridging.
Yeah. And, the other part of it is Indians also spend a lot on healthcare, private healthcare, out of pocket, right? And you simultaneously have this question of distrust because most women, when they interface with the healthcare system, have had some unfortunate experience. I mean, when I talk to my friends, even the rich elite friends and the kind of experiences they've had during childbirth, I mean, I'm frankly astonished anyone goes to a doctor in India sometimes. So there are so many layers to this. So the first part, I guess, is the healthcare service actually needs to be forthcoming, right? It needs to exist in that particular village or that particular district. Then the next part of it is, now we need to encourage people to come there. And the demand side intervention that we discussed could be like health insurance or cash transfers or things like that. Now, to kind of motivate people to show up, there is going to be more information and more access, and this is basically provided through the ASHA worker. So it's a supply side intervention in that they're strengthening the district level health center as a supplier, but it's also demand side partial intervention in that they're actually going and talking to the women and telling them the sort of buffet of options that they can use at these centers, right? Which of the services are free, which of the services need to be paid for, and so on and so forth. And what are the things that their children can benefit from and not just them. So is that a good way now to think about ASHA workers, and do they operate the same way in every state and every district?
That's an excellent way to think about ASHA workers in general. However, in terms of how do they operate in different states and different districts, that is where the variation is coming in. And this is actually quite unfortunate because when I'm thinking about the current unionization, so there's a lot of media articles surrounding the unionization of these workers, particularly after COVID, because they were seen to be very vital workers. in the healthcare system.
And overworked and underpaid and they're not part of the government infrastructure in terms of benefits and status and all the other important things.
Precisely. And that is where they deviate from the other community health workers in the Indian context, right? So all that they are fighting for is equal rights, right? That we are healthcare workers, so please respect us like healthcare workers. And what is happening across the Indian context is that you have states like Odisha as well as in Bengal, where they are being paid an honorarium, sort of like how Anganwadi workers are being paid, of a per month wage of 2,000 rupees, which is still pretty limited, especially when you consider the huge impacts that they're having on population health. But in other states, like say in Tamil Nadu and Kerala, they're now getting paid 7,000. So as you can imagine, this huge deviation in terms of their remuneration is also not very clear, first of all, because the state government is the one who's making these decisions, but the money is coming actually from the central government for the ASHA deployment, right? So it's very hard for the state government to really determine that, okay, how much am I going to pay the ASHAs and how much am I going to pay the healthcare institutions, because these are both supply side incentives. And like you said, India is very much, particularly at the district level, it's very much decided by how much is the income at that district. And when you're thinking about a lot of these districts which have poor health outcomes, they also have really low socioeconomic and demographic statuses, like their income levels are low, their literacy levels are low. So it is a huge political challenge for these governments to really determine how much can we pay these workers. And I'm sure it's not really coming from a sense that, okay, let's see how to undercut these workers. It's really coming from a fiscal or a budgetary challenge of how to really allocate these funds in a way that is justifiable. So for instance, because ASHAs are being paid on a piece rate basis, let's look at some of the incentives that they are receiving, at least when the policy was being implemented. So when you're talking about something like delivery, institutional deliveries and how they're facilitating it, they were being offered from 600 rupees to 200 rupees. It was based on the fact of whether or not the mother was located in a rural versus a urban center.
Okay.
Right? And why did this happen in the first place? This happened, first of all, in low focus states, right? So the government of India, they came in 2005. They implemented this really huge policy called the National Health Mission. And that is when the ASHA workers were implemented. So then they kind of make this decision that, okay, in these very, very high priority states, I am going to be deploying these ASHAs at both the urban and the rural level.
Okay.
So at the rural level, I'm going to be paying them 600 rupees for every institutional births. And at the urban areas, I'm going to be paying them a little bit less, just because of the fact that rural areas are much harder to access than urban areas.
They're underserved.
Exactly. So this is why the incentive was more. Now, ASHAs were not just hired to be, to be bringing about changes in institutional deliveries. They were also being brought in to increase, say, immunizations for the children that were being born to these women. Now, when you think about institutional deliveries, though, the incentive that is being offered to the ASHA in the same setting was around 250 rupees. That's already so much less. And then when you're thinking about family planning, the ASHAs were not being remunerated at all for providing this kind of information access, but they were being given, say, like 1 rupees to distribute condoms and birth control pills. So this incentive, there was a huge variation in the incentives, right? So if you think about it from a standpoint of a worker who's going in and they have, let's say, limited hours. So this was the deal, is that when ASHAs were introduced, they were only allowed to really work 2 to 4 hours a day and for 4 days a week, which of course is not the case today.
Also, I like the idea that someone thought 2 to 4 hours a day, you can squeeze in the labor of a pregnant woman in 2 to 4 hours. Like, the whole thing is laughable when we design some of this stuff.
Exactly. And it kind of goes
But I
to
hope
show,
it's on average.
it kind of goes to show what happens when it is men deciding these kinds of policies, reproductive health policies for women, right? You don't really recognize how long, let's say, on the labor and delivery floor. So I work in an OB-GYN department right now, and in the L&D floor, it can take up to like 48 hours sometimes, right?
Yeah.
So I mean, it's a little insane to me that it would that people would think that okay, this is going to be enough, and no wonder these workers today are working sometimes 80 hours a week.
Yeah.
Right. And so that is why they are so overworked. Now, obviously, you can think about a situation like this. If you were a worker and you are now getting incentivized more for a delivery versus for family planning, then would you not want to substitute more deliveries for family planning? Of course, you would, because that is where your incentive lies. And we've already shown, multiple researchers have shown in low middle income countries, it's that incentives really drive the performance of the workers. And it's in particular not just, social recognition and other incentives, it is pecuniary or monetary incentives. This has been shown time and time again that this is and this is kind of econ 101, right? If you pay me more, I'll perform better. So that is exactly where this incentive design is kind of coming from, but it doesn't seem to be designed as something which could be like working out in the long term unless there is a revision. And that is exactly what my paper is trying to make people think about, that in along those lines, that on the national landscape there has been this policy which has been wildly successful. So why don't we think about remunerating the people who have made these policies successful?
You've laid this out so well for us, but as an economist, now I'm thinking about the nightmare of measuring this, right? So, how do you actually measure this kind of supply side intervention? Because, as you just said, it has so many moving parts. I mean, one, you just literally have to count up the number of workers and associate them with districts. The districts are complicated because they have become too big and our districts have split up and, all those sorts of issues. But also, like all the other kinds of services they offer, the difference in rates. So, can you walk us through how you've actually measured this and constructed your data set?
Yes. So here is how I created a novel data set using administrative data from the Health Management Information Systems, which was collected by the Ministry of Health and Family Welfare. So I created this district level monthly panel data set. And I use the number of ASHAs who are receiving a performance incentive across public as well as private institutions. And I normalize that. In other words, I just divide that by the population using the census of 2011. And here, this is my rationale. So now, because ASHAs are being allocated on a 1:1,000 rule, so the rule by the National Health Mission of the Government of India was that there must be one ASHA per 1,000 population. So I exploit this and I use this as my supply side policy variation. And using my now treatment variable of the number of ASHAs per 1,000 population, I am able to link it to my household surveys. So the pre-survey that I use is the district level household and facility survey, which is collected before the implementation of the National Health Mission. And I use the fourth round of the National Family Health Survey. Both are being collected by the IIPS, International Institute of Policy Studies, Population Studies in Mumbai. So using this, I'm able to compare the long-term outcomes such as antenatal care, institutional deliveries, and family planning before and after the policy rollout across temporal variation, which is the policy rollout, as well as the spatial variation, which is coming from the placement of the ASHAs at the district level. So I find that for each additional ASHA per 1,000 population, there is an increase between 2 to 4% in the utilization of reproductive health.
Yeah. What does that mean really? Can you unpack that up for us a little bit?
Yes. So how do I put these results into perspective? So here is where I also bring in this different treatment intensity. So just in case we didn't want to think about looking at the ASHA placement, and we might have thought that, okay, just because there are ASHAs, perhaps people are not using that service, right? So I also create this other intensity measure where I look at the utilization of ASHA workers. And this could be utilization along any measure. So it could be you coming into contact with an ASHA worker during your antenatal care. could be you going to an ASHA when your child is sick. It could also be you going to an ASHA for family planning workshops or the distribution of sanitary napkins, etc.
Yeah.
Right? So all of these factors are going to be playing a huge part in terms of your uptake of the services. Right? So I find that from the National Family Health Survey in 2015-16, that there were 334 women per 1,000 women in that particular survey who were using this service. Right? So if I'm now trying to put that into context, I'm actually finding numbers which is close to 17 to 20% of an increase, right? So
Yeah.
obviously, as we know that these numbers, they could be biased because of selection issues. But these are actually the numbers. So if you're actually thinking of 100% utilization of these services, that is how large these numbers could be. It could be the order
Yeah.
of 20%, right? And it's only because I only measure the access that I'm finding these smaller numbers.
So now, how do we know that this is not because of other factors, right? It's not an information factor, or they heard about it on Facebook or WhatsApp or something else. Like, how do you actually identify that the causal effect is because of the policy intervention?
So that's a great question. So one way that I do try to kind of assess this, particularly because we know that in the literature on kind of information diffusion, it has been shown that information is also shared by your neighbors. Right. So it could be, say, like you said, a WhatsApp group is being created, and my neighbor is like, okay, hey, there's this new policy. Why don't you use it? How do I know that it's driven by ASHA? So I test for this by looking at the different social groups that are in that particular neighborhood. So controlling for, say, Hindus versus non-Hindus in the religious factor, or if I'm looking at caste groups, I don't really see any changes in their uptake of these reproductive health services, which is driven by social groups, meaning that it is the community health worker intervention that is driving this uptake of reproductive health services, and not just the fact that my neighbor who is in my community or in my social group who is sharing this information, and therefore I am taking up these services. So, the way that I measure my identification strategy is using a difference in differences design. So, a difference in differences design is like the name suggests, it's a double difference strategy. Right, so I mentioned previously that I'm looking at a spatial variation of the ASHAs, which is the ASHA placement in the district. That's my first difference. The second difference is coming from the timing of the policy. So the before and after. Since I'm looking at long-term effect of this policy, I look at the ASHAs who are placed obviously after the policy was universalized. So post 2009, which is when I have my data available for ASHA placement. Before that policy, I just assume that there are no ASHAs in any of these districts. So they just get assigned a treatment of 0.
Okay.
The only limitation to this is that, of course, there are other community health workers who are existing during this time. So later I do try to use a placebo treatment where I'm trying to see that do these other community health workers, are they able to kind of change this policy, or are they able to increase the utilization? But I don't really find effects in that either. Right? So it is the ASHAs kind of who are driving this effect. So in terms of thinking through this whole difference in differences strategy that I now construct, is that rather than relying on whether or not an individual mother has reported using NHM benefits, which could, like we said, is subjected to a lot of selection biases, I'm using a very objective district level measure. And the district level measure, it's been shown in the literature to have a much more of a lower bound of effects, which is why I'm underestimating, if anything, the effect of this policy. And
so, what is the district level measure that you use?
So the district level measure here is the placement of the ASHA worker. So the number of ASHA workers who are being paid the incentive, the performance incentive, when a birth of a child is being recorded in an institution, whether private or public. I also supplement this by using another treatment, which is the utilization of the ASHA workers. So both from access and from use, I find very positive and significant effects of this policy on use of these reproductive health services.
Now this is interesting. Like the way in some sense, what you're telling me is that the policy intervention itself lends itself to measurement, right? Because these people are paid like a piecemeal rate per service that's provided. Then you get a pretty granular view of how much their service is being used, as opposed to in a regular survey. I mean, some of it could be memory issues. Some of it could just be people, when a serious person shows up at your door and they ask you, did you go to the health clinic nearby, you're likely to say, yes, I did. Right? Nobody wants to admit to going to a quack necessarily, or going, not using services that are provided. You want to sound sensible and sophisticated when a government person shows up at your door. So to that extent, it makes much more sense not to just use survey data, but also use these data, which is literally how much of a particular service was deployed and supplied. And presumably there's someone in the rural mission looking into not paying people if they didn't do the service, right? So there are like multiple levels of checks at some level.
Precisely. Like you said, there's always this social desirability bias that occurs when you're collecting survey data.
Yeah.
And that is kind of the concern when you're using just survey data to kind of assess policy impacts. And that is exactly why I use this combination of administrative as well as survey data to answer my research question in a much more holistic way.
Yeah. And the other thing about survey data, I also learned this from a couple of papers I was reading. It's not the women who are of reproductive age who are always giving the answers. Usually there's someone else in the household who's answering on their behalf. Yeah, we took them to the clinic. So there is already, one is, of course, social desirability bias, but there's also like a whole number of issues on who's actually answering the surveys themselves. So in some sense, having all these other ways to triangulate how much of a service is being provided is pretty helpful. In this case, the supply side can also tell you how much it's being used just because of the way the intervention's been designed. Okay, so now, how does one think about like the buffet of services, right? When you talk about a birth at an institutional, a birth in an institutional setting as opposed to having a midwife come home, right? So that's one kind of service that's being used. But like we talked about, most women don't use that service too many times in their life. But there are a number of health checkups, right, which may happen multiple times a year. It may be contraception, which is maybe you need to be prescribed once a quarter. It could be sanitary pad use, which is literally every month, right? So what is a good way of thinking about all of these different things, especially given the fact that you told us previously that ASHA workers were more likely to supply or adjust their health services to the births versus some of these other questions?
So if I understand your question correctly, Shruti, and please correct me if I'm wrong. So you're asking that how did the ASHA workers kind of what sort of like competing interests they had in terms of like saying that, okay, this is the service that I'm going to offer versus another? Is that
No,
kind
I
of
think the service you're measuring pretty well. But I'm
Right.
saying, do we have a good way of thinking about what else the women start using? Because they're not going often enough to
Right.
give births. No, birth to they're doing only twice in their
Yes.
life.
That's right. That's right.
And you mentioned that ASHA women have this incentive to do more births than they have to do other things, right?
That's right. And this is kind of where this whole information channel and social norms and things like that, this is where it plays a very, very big role, right? In kind of deciding what is it that will not just kind of impact women's health and reproductive health, but also other forms of healthcare access and utilization, right? When you're thinking of something, a recent paper that I'm working on in this context is on gender-based violence. So we all know that gender-based violence is a global health concern. However, we don't really know enough about what can change these sorts of decisions that is being made. So, and it's been shown that because of this information channel that ASHAs are being able to provide to households, not just to women, and also this role model effect, right, which is very unique. It's coming in from the ASHAs being women and these like role models for the community. This really affects women's empowerment in general. And that also has kind of interplay not just in women's mobility and financial as well as other forms of autonomy. It also definitely affects their utilization of all types of healthcare services, right? And it also does affect their labor outcomes.
So we've talked about the policy intervention, what are some of the policy implications of what you're telling us, right? So in some sense, the ASHA worker, policy, as you said, it's pretty successful. It's been rolled out all over India. We have more than 1 million ASHA workers, right? So in that sense, this is a massive intervention that's been made, which is vastly successful. But if I had to pick up from everything else that you're saying, you're basically saying we need to invest more in this, right? So is the policy implication that we need more ASHA workers in every district? Is it that we need to pay them better? Is it that we need to train them better? So what is a good way to think about the policy implication of this particular service? And now, again, I imagine you're going to tell me there are differences at the state level.
Absolutely. And you've exactly predicted what I'm going to say. However, I will start by saying yes to all. Right? Yes to being more workers, yes to paying them more, and also yes to having a better designed incentive system. However, I know that every single person, whether at the micro or at the macro level, we're all doing constrained optimization. And so is the Indian government. Right? So, unfortunately, while more is kind of better and we want to move to the right-hand side of the indifference curve, it's not always possible because of the budget constraints. Right? So, here, what I'd like to say is that we should definitely invest more, right? But it's not just in more workers. I think that the answer is in designing a much, much better policy that incentivizes whatever it is that the Indian government is now choosing, right? Because at the time that the policy was implemented, this was for a safe motherhood initiative, right? It was to complement the Janani Suraksha Yojana. However, what's happened right now is that we've unfortunately had this whole thing where now Indian fertility level has fallen below the replacement rate, right? So it's not just enough to say that, okay, I've now provided safe births. I think that that's great on the extensive margin, but on the intensive margin, it's also the quality of care that matters, right? And so therefore, training the ASHAs is very, very integral here. But training, it will cost more resources, right? So kind of redesigning these training programs and rethinking the incentives that is being offered to ASHAs so that they can meet the policy that is being proposed by the Indian government is really pivotal at this turning point.
Yeah. You said something really important right now, which is we don't just pick and choose policies based on what's desirable. It's based on what is possible and beyond possible, what makes sense when we do the cost benefit analysis, right? So if we say, let's invest another 100 rupees in an ASHA worker, the question is relative to what? So I guess here I will ask you, do you find evidence that supply side interventions are actually more cost effective than the demand side intervention? Because that would be a simple way to start to look at this problem, right?
So this is actually a very interesting point because yes, in my case, for instance, when I'm trying to do a cost-effective analysis, I do think about the value of a statistical life and then I do this whole comparison. And I do find that very much so that even if you're staffing one ASHA per 1,000 people, as the guidelines are suggesting, the cost is coming to about $70 to $100. This is taken from the 600 rupees that you're giving to the ASHA worker at the 2015. So the ratio of the benefits to cost is enormous because the value of a maternal life lost is about 288,000 USD at this level, right? So you can just imagine that, if this is like really goes to show that a supply side incentive like this is really, really going to be improving outcomes much more than a demand side, because at the demand side, you are actually paying each woman an X amount of money to be delivering at the birth center, right? Yeah. But here instead you're employing a cohort of community health workers, and these cohort of community health workers, they can kind of support each other, they can pass along this information and train each other, and they can kind of go out there and they can not just facilitate one birth, but multiple births. So you're thinking about the same policy, but from a supply side. So it's like having a multiplicative effect as opposed to on the demand side where you're just aiming one person at a time.
Well, yes and no, right? Because the demand side effect also means that if I have a greater uptick in terms of demand of going to these, health service clinics and so on, then I'll take people along with me. Most women never go anywhere alone. You spread the word and say you had a good experience. So even demand can sort of, start clustering in certain places. So, I understand what you're saying, that there's a difference between paying each woman versus paying a particular worker who sort of services a particular community. But I still think I would disagree with you on I don't think the impact on the demand side intervention is just each woman, because at the end of the day, it means more uptick for the supply.
Yes, absolutely. And what you pointed out is very, very crucial here. It's the information channel. Like whether it's the ASHA who is informing the mother that, hey, giving birth in a healthcare center is going to be safer for you, or if it's the mother informing their friends or their sisters or their sister-in-laws, it's still the information channel. And it boils down to that access concern, right? Because information to me is a more supply side mechanism.
Yeah.
So unless you have that information, and I think of the ASHAs as kind of that like focal point. They are giving this information, they are also facilitating the access. So they're combining these two very important measures. And like you said, without the demand, there can be there's no point of having a bunch of like ASHA workers when people don't really want to take up this service, right? So I think that it has to coexist. Both are important and very, very, necessary for the reproductive as well as population health landscape in India. But the argument that I'm trying to make in my paper is that supply side incentives and supply side measures in particular are understudied. And that's also because they don't have such a high, obvious and immediate effect. Whereas demand side, you can kind of measure immediately that this was the impact of the policy. And that is why it makes supply side incentives a little bit trickier to design and to kind of advocate for. And that's why I try my best to push hard as much as I can to show that supply side measures, they really do have this kind of an effect. And sometimes it's this understudied effect because of this multiplicative nature that it will have only once you give the policy time to reap its benefits.
Yeah. And now, luckily, we have time, and we've also seen a pandemic, and we've seen their impact on non-reproductive services, on child services, on vaccinations. And the broader point of what I really loved about your paper is it's kind of hidden in every section that you write about, which is you see in every state and in every district this building of state capacity when it comes to healthcare services, which was previously missing. Right? And some of that state capacity is missing because of personnel issues. It's too costly. We never roll this out. Some of that state capacity is missing because no one wants to show up at the clinic, so then no one develops the clinic further. It's just being used, as a storage facility or some other nonsense. So this constant building of healthcare capacity at every district, I think that might be one of the loveliest things about the ASHA worker program. And capacity is not just buildings and clinics, right? It's actually people and their human capital. So the fact that there are a million women in India who can actually do this and help other women, it's quite extraordinary.
No, I totally agree. And it's not just the fact of like building a hospital, but it's also who is running that hospital, right? So it's twofold.
So couple of questions. You sent me a whole dissertation and I've read it, but I don't think we have time to go into everything. But I think of your dissertation very much as, like you mentioned, looking at supply-side interventions and can they work? So, we talked about this reproductive health and pregnancy situation. You also have a paper on when you look at supply-side interventions beyond a pregnancy situation, right? So what happens once a child is born? Can you briefly walk us through that and, before I let you go?
Of course. So, like you said, once a child is born, the constraint is going to be shifting from healthcare to childcare.
Yeah.
Right. So in my second chapter of my dissertation, I look at the impact of the Anganwadi daycare system, right, which is a very unique policy in the Indian landscape as well, because the Anganwadi system is twofold. The Anganwadi Center is both providing the supplementary nutrition, which has been studied by a lot of researchers like, say, Saravana Ravindran. And he's shown that this policy has had a lot of very positive effects on child health outcomes as well as maternal health outcomes, but he doesn't really find any effect on a kind of employment measure. So I dig a little bit deeper into this to see whether or not childcare can boost maternal employment. And if so, what is the cost effectiveness of such a policy? Right. So affordable daycare, for instance, is a huge determinant when you're thinking about when mothers of young children would be staying in the labor force, as well as would they, particularly for them in the margin, right, would they be going into work?
Yeah.
Right? So
this is a nightmare in India. India has some of the lowest levels of female labor force participation. A lot of the labor force participation in rural areas doesn't even get calculated well because, the farm is next to the household. So even with all of that, we still have this major problem. So thinking about local daycare and Anganwadi facilities for an infant or a child for a young mother seems like a really important question right now in India.
Precisely. And you've actually hit the nail on the head, because that is exactly where I find the impact of this policy. It is in agricultural, like women who are working in the agricultural sector, as well as who are informally employed. They are the ones who see the huge benefits of this policy, right? And you're thinking about rural women as well, because if you're in an urban setting, perhaps you have access to a bunch of other like institutions. And I also kind of, in this case, we're also thinking about informal childcare institutions in the Indian context. So you can think about an older sibling kind of taking care, particularly older sisters, and also maternal grandmothers. That has been shown to be a huge factor. So in my paper, I don't really find any effects of any other kind of informal networks in the household. And I'm able to show that it is the Anganwadi daycare that is being able to boost maternal employment. And particularly the mechanism that I explore is that of child health. So like I had mentioned, Anganwadi centers, they are providing these supplementary nutrition policies as like for pregnant as well as nursing mothers, as well as for their young children, right? But this is only given from 0 to 2 years of age. I exploit the variation of that 0 to 2 years age, using them as the control and using the 3 to 5 years of age as the treated cohort. Why? Because the 3 to 5 years of age, they get this very unique thing called the ECEE, the Early Childhood Education Initiatives.
Yeah.
And that is the preschool or the Anganwadi daycare system that I'm trying to use. And I do find the effect is pretty large. So for every 1 standard deviation increase in the daycare or Anganwadi daycare, I'm finding an effect size of 8% increase in maternal employment.
Which is huge.
It's a huge increase, especially
given how low the base is in India. This would be fantastic.
Precisely. And this impact is basically identical to the impact that a policy like MG Narega is finding, right? But it's at a cost which is at a fraction of the MG Narega policy. So this is again going back to that whole demand side incentive, which is costing the Indian government more, versus this supply side incentive, which is a lot easier and is much more cost effective.
And presumably something the women actually want.
Yes, precisely, because it's been shown that there has been a boost in the maternal employment, right? Whereas paternal employment, very interestingly enough, of course, has not changed, because in my sample, almost there's universal, men are all employed in the workforce, right? So I don't really find any effect there.
Yeah, that's another charming side effect of the social desirability bias in rural household surveys, where everyone is employed, right?
Precisely.
No one is unemployed. No one is underemployed. No, but this was fascinating. Thank you so much for sharing this work with us, Nayantara. It was a pleasure speaking with you.
No, it was a pleasure for me as well. Thank you so much, Shruti.
Ideas of India is produced by the Mercatus Center at George Mason University. If you enjoy this podcast, please subscribe on Apple Podcasts, Spotify, or your favorite podcast app. Help us grow by giving us a rating and leaving a review. Follow us on Twitter at @SRajagopalan and at Ideas of India. Also check out our initiative commemorating 30 years of India's market reforms at the 1991project.com.